The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'll introduce our speaker. Dr. Eric Hollander is a professor of psychiatry and behavioral sciences at the Albert Einstein College of Medicine and the director of the Autism and Obsessive Compulsive Spectrum Program and the Anxiety and Depression Program at Montefiore Medical Center and Albert Einstein College of Medicine. He has edited 20 books, including Autism Spectrum Disorders, the Textbook of Autism Spectrum Disorders, the Textbook of Anxiety Disorders, and the Clinical Manual of Impulse Control Disorders. Dr. Hollander has served as a principal investigator for a number of federal grants, including the NIH Greater New York Autism Center of Excellence, the NIMH Research Training Grant in Psychopharmacology and Outcomes Research, and the Department of Defense CBDV in Autism Treatment Study. You can type your questions into the questions section now and throughout the talk. He'll answer as many as he can at the end. And now I will turn this over to Dr. Hollander.
Okay, well, thank you, Denise. It's really a great pleasure to be here today. And my name again is Eric Hollander, and I'm with the Albert Einstein College of Medicine and the Psychiatric Research Institute of Montefiore Einstein, where I direct the Autism and Obsessive Compulsive Spectrum Program. I'm going to be talking about research using a non-psychoactive form of cannabis extract called CBDV, or cannabidivarin, to treat core and associated symptoms of autism spectrum disorder, and also how they manifest in a related rare condition called Prader-Willi syndrome as well. So presenting today has been funded in part by the Department of Defense for a CBDV versus placebo and ASD grant. I'm also working with GW Pharma, who's provided the cannabidivarin for the Prader-Willi and the autism spectrum disorder studies, and also received funding from the Foundation for Prader-Willi Research as well. So I'd like to highlight other members of the research team at Montefiore Einstein. Bonnie Taylor is a research psychologist, and I'm going to be giving her contact information at the end of the talk. So if people are interested in participating in any of our clinical trials, they can contact her. I'd like to highlight Vera Nezgovarova as well, Yin Zhao, Casara Ferretti, Tarini Vats, Nalifa De Silva, Aaron Shanahan, and other members of the research group. So this is our book, Autism Spectrum Disorders, published by American Psychiatric Publishing, and it's a nice overview, which is helpful both for clinicians and people doing research in this area. And it reviews the different clinical symptoms of autism spectrum disorder, various causes of ASD, and then both common treatments and novel treatments of autism spectrum disorder. You can get this book on Amazon.com. So here are the core and associated symptoms of autism spectrum disorder. And you see here in the middle are patients with autism. In the DSM-5, one of the changes is that the three core symptoms of autism have been boiled down to two core domains. And one are the social and communication deficits that have been boiled into one domain, social communication difficulties, including the back and forth of social communication. And then the second core are these narrow restricted interests or repetitive or compulsive behaviors. So rigid behaviors or repetitive behaviors is the second core domain. And if you have marked deficits in both the social communication problems and the narrow restricted interests and repetitive behaviors, you would meet the criteria for an autism spectrum disorder. The other main change in DSM-5 is that these different categories of autistic disorder, pervasive developmental disorder, not otherwise specified, and Asperger's have been boiled down to one grouping, which are the autism spectrum disorders. Here we see also that there are a number of these associated symptom domains that shape the expression of autism in any particular individual and are important targets for treatment, and that contribute to the overall distress and the functional impairment in different individuals with ASD. So we have significant impulsivity and aggression, or what we might call the disruptive behaviors. But this is a major challenge in terms of managing some individuals with ASD who can have aggression or self-injury, temper tantrums, or other kinds of explosive kind of episodes. And that's a major source of functional impairment and impairment in terms of overall caregiver stress or quality of life for individuals and their family members. Another domain are the EEG abnormalities, or in some individuals, seizures. There's a high comorbidity between epilepsy and autism spectrum disorders. So you have some individuals who have both seizures and autism, but many individuals with autism spectrum disorder who don't have epilepsy, some of those individuals may have some epileptiform-like activity on EEG, and others don't have any EEG abnormalities. And then some individuals also have features of attention deficit hyperactivity disorder. That's a common comorbidity, and that is often something that can be treated as well and can complicate the course as well. And then we see that these different core symptom domains, so repetitive behaviors or social communication problems, or the comorbid conditions like obsessive compulsive disorder or impulsive aggression or ADHD or EEG abnormalities or speech or language related issues or social anxiety type problems can sometimes run within families as well. So these different symptom domains sometimes can be seen in first degree family members as well, even if they don't have the full ASD diagnosis. So let's take a look at some of the social deficits that occur in ASD, and these can include things like problems with empathy, understanding that other people have minds outside your own mind and may see things from different perspectives, problems with eye gaze, the nonverbal forms of communication, so reading facial expression or body gestures, and then reciprocal social interactions, which are the back and forth of social communication. Individuals with ASD often have significant repetitive behaviors. And if we look at the type of symptoms, we see different factors. There are some individuals who have obsessive concerns. They may worry about contamination, or they may want things to be perfect or just so, or they can have intrusive or disturbing thoughts. There are other individuals who have typical OCD-like compulsive behaviors, washing, checking, repeating, putting things in order, certain rituals involving eating. And then there are a group of individuals who have what we would call the lower order self-stimulatory types of repetitive behaviors. And these can be hand flapping, they can be head banging or self-damaging kind of behaviors, rocking, and other what we call addictive-like or impulsive type arousal regulating type behaviors. And then finally, individuals with ASD can have a lot of hoarding kind of behaviors as well. So the current treatments that are available and frequently utilized in individuals with ASD are maybe 4 different classes of medicines. The first being the atypical antipsychotic type medications, risperidone or aripiprazole. These medicines are approved by the Food and Drug Administration to treat children with ASD who have substantial disruptive behaviors, the aggression or the self-injury or temper tantrums, for example. And these medicines are effective. They have a large effect size, but they may be complicated by some adverse events or side effects that may occur either shortly after starting the medicine, or they may develop over time. We're involved in a study, this LAP-01 study, funded by the National Institute of Child Health and Development, that looks at the long-term effects of medicines like risperidone or aripiprazole in patients with ASD and other conditions, and carefully follows individuals for things like weight gain and metabolism, for example. Another class of medicine that is frequently used by clinicians to manage some of the symptoms of ASD are the serotonin reuptake inhibitors, medicines like fluoxetine or fluvoxamine or citalopram. And some studies have shown that these medicines can be helpful for treating some of the repetitive behaviors and are often used to treat comorbid anxiety problems like social anxiety or comorbid depression, for example, or generalized anxiety or worry. These medicines also may have some side effects in that there are some individuals who may have some activation. So on SSRI type medicine, some individuals with ASD may get activated. It may interfere with sleep, or some individuals may have more of the disruptive behaviors, for example. So we generally start with low doses and go up slowly and monitor for risk versus benefits. A third class of medicines that are frequently used to treat patients with ASD are the anticonvulsant type medicines. Medicines like valproate or Depakote or lamotrigine or Lamictal. These medicines are used to treat individuals with epilepsy or seizures, and they're also used to treat individuals who have a bipolar disorder or experience mood swings, highs and lows. And these medicines often may be used to treat the irritability or the disruptive behaviors in ASD, or to manage the comorbid seizures or epilepsy. This class of medicine also may be effective, but may have some side effects, including things like sedation, weight gain, rash, or elevated liver function tests on blood work. And then finally, another class of medicine that are frequently used are the stimulant type medicines that are used to treat attention deficit hyperactivity disorder in children. Medicines like methylphenidate Ritalin or amphetamine Adderall, for example. These medicines may target the attentional difficulties, impulsivity, or hyperactivity, but they may also be associated with adverse events or side effects, decreases in appetite, activation, problems with sleep, or irritability. Now, we've conducted a series of studies with serotonin reuptake inhibitors like fluoxetine or Prozac in both children and in adults with autism spectrum disorder who come in with a lot of compulsive behaviors. And that over time, what we found in our studies is overall a reduction in some of these compulsive behaviors or repetitive behaviors, particularly the more OCD-like compulsive behaviors, and particularly with those individuals who have high compulsivity. Patients who also have some irritability are less likely to have a sustained placebo response and are more likely to show a significant difference between the active medicine and the placebo medicine. So what I'm going to be talking about today are experimental therapeutics in ASD and Prader-Willi syndrome using these non-psychoactive cannabinoids like CBDV, cannabidivarin, or related compounds. And these medicines may have important effects by modulating the balance between excitation and inhibition in patients with autism spectrum disorder, And they may also exert their effect by reducing immune inflammatory mechanisms that may play a role in at least a subgroup of individuals with autism spectrum disorder. And in our studies that are funded by the Department of Defense and GW Pharma and the Foundation for Prader-Willi Research, we're using cannabidivarin or CBDV to target symptoms of irritability or the disruptive behaviors, but we're also looking at the impact of these compounds for the repetitive behavior domain and also for the social communication domain. So 3 different domains in patients with ASD symptoms. So here's the cover of a Newsweek magazine called The Blunt Truth About Weed and Autism. And it highlights work with a young girl, Charlotte Figge, age 7, and her mom, Paige Figge. And this is at using a Charlotte's Web strain of a cannabinoid to treat her epilepsy and also to look at its impact on other kinds of symptoms seen in ASD. And I'm going to get back to some of the studies that have used whole plant cannabis or different compounds in the cannabis plant, and the idea that there are anecdotal reports across the country that have been highlighted, for example, in a recent conference hosted by Autism Speaks, and that have also been sort of collected as anecdotal case reports by a whole plant for autism as well. Now, doing studies with cannabinoids in autism spectrum disorder, again, we're using these compounds to target these 2 mechanisms of action, the excitation, inhibition, and balance. So there's evidence in autism that there's too much excitation in the cortex and not enough inhibitory tone. And this excitation, inhibition, and balance can be manifest, for example, by disruptive behaviors or temper tantrums, or it can be manifest by seizures, for example, or epilepsy. And also to target this mechanism, immune inflammatory mechanisms. And, we and others have done some studies suggesting that a subgroup of individuals may have some activation of immune inflammatory mechanisms and may be responsive to some treatments that dampen down these immune inflammatory mechanisms. Now, in order to do studies with these type of compounds in ASD, there are a number of barriers in terms of research. There are legal related issues and regulatory issues working with cannabinoids or cannabis that are set by the Food and Drug Administration and the Drug Enforcement Administration and the Bureau of Narcotics. There are complex state-by-state legal and regulatory issues as well, in addition to federal guidelines. There are issues with quality control. So you need to know the source of the compound, and then you also need to know whether the milligrams listed for CBDV or CBD or THC are actually the milligrams that show up in whatever medication is being administered. There are safety-related issues as well with all plant-based compounds and other kinds of medications. And any individual clinician, for example, needs to carefully weigh the potential benefits of a treatment versus the risks and match those risks versus benefits to any particular individual patient as well. And that will include, past history, comorbid medical problems, other psychiatric conditions, family response to different treatments, past history of response to different treatments, adverse events, and so on, and that we have to go through a differential diagnosis as well. Clinicians need to know more about alternative treatments because many families and patients may be taking alternative treatments, and with those alternative treatments come as well potential benefits and potential risks, as well as potential for drug-drug interaction. So these alternative treatments may interact with other kinds of medications as well, and clinicians need to know about those potential drug-drug interactions as well. Finally, what we need to do as clinicians for individual patients is to figure out what are the target symptoms that are causing the most distress and the greatest interference in overall level of functioning, or the greatest caregiver burden on families as well, and individualize our treatments for the particular target symptoms in that particular patient. And then we need to be guided by evidence-based treatments. And those evidence-based treatments can be from multi-center, double-blind, randomized trials. They may be from cohorts, for example, that may be collected in different ways. They may be from epidemiology studies. They may be from anecdotal case reports as well, and expert consensus. And you need to look at all of the available evidence and weigh the strength of that evidence and potential risks versus benefits in terms of judging evidence-based treatments as well. So in terms of personalizing treatment decisions, you want to look at the evidence, the patient data, the basic science, animal models, epidemiology, clinical reports, randomized trials, systematic meta-analysis type reviews. You want to look at various patient as well as physician factors, cultural beliefs, values, experiences, and education. You want to think of all of the regulatory guidelines and legal related constraints, the policies and laws, community standards, time, reimbursement costs, things like that, guidelines, ethical issues, and knowledge shape clinical decision-making for individual patients. Now, within our bodies and within our brains, we have an endocannabinoid system. This is the cannabinoid system that occurs naturally occurring in the body and the brain. And these endocannabinoids include at least two different compounds, this anandamide, or AEA, and the 2-arachidonylglycerol, or 2-AG. So these are the endogenous cannabinoids, or endocannabinoids. And then we have the plant-based cannabinoids, or the phyto-cannabinoids, which include things like THC, CBD, CBDV, and many other compounds as well. These compounds may bind to the endogenous cannabinoid receptors that are found in the brain, central nervous system, and particularly the immune system as well. These cannabinoid 1 receptors in the brain and the CNS, and these cannabinoid 2 receptors that are found throughout the immune system. The endogenous or endocannabinoids and the phytocannabinoids may include an active ingredient of marijuana or cannabis, the delta-9 tetrahydrocannabinol, or THC, which is the psychoactive compound in cannabis, which can bind to cannabinoid 1 and cannabinoid 2 receptors, as well as these other G protein coupled receptors. And then these other endogenous cannabinoid agonists that have been identified in the body and the brain, this anandamide and the 2-arachidonylglycerol, or 2-AG, and this may be related to lipid arachidonic acid compounds. Then there are other ligands, which may be peptides, that may also bind to the cannabinoid receptor. So these endocannabinoids are different than typical neurotransmitters. They're more like neuromodulators. They are often found, these neuromodulators or endocannabinoids, in the postsynaptic receptors. And they may work via the synapse through this retrograde transmission and influence these receptors that are found in the presynaptic nerve terminal, these cannabinoid receptors and other G protein coupled receptors, and influencing the endocannabinoid system, or these neuromodulators, may then have a powerful impact in a secondary fashion on neurotransmitters, including both the release of neurotransmitters and the reuptake of other neurotransmitters. These cannabinoid signaling pathways also play a role because after they hit these receptors that are seen on cell membranes, these CB1 and CB2 cannabinoid receptors, and these THC or these endogenous cannabinoids like AEA may bind to these receptors in the cell membranes. They may activate cell signaling pathways. So for example, one of the cell signaling pathways is this cell cycle pathway, this MAPK mTOR pathway that's involved in neuronal growth and cell replication, or they may influence things like DAG and the breakdown of 2AG, for example, into other kinds of anandamides. Now, these plant-based cannabinoids also include the non-psychoactive compounds, and these include CBD or cannabidiol that you hear a lot in the media these days, as well as CBDV or cannabidivarin, which is a distinct compound. It turns out that these non-psychoactive compounds found in the cannabis plant may not bind to the cannabinoid 1 or 2 receptors. They may bind to other G protein coupled receptors, these GPR55 receptors, or they may bind to these other channels called TRP or TRP channels, or they may bind to other receptors like the serotonin 1A receptor and so on. So they seem to have a distinct mechanism of action, partially overlapping but partially distinct from psychoactive compounds like THC. These endogenous cannabinoid mechanisms and compounds that are found in the body are found in 3 different components. One are these postsynaptic neurons and presynaptic neurons in the central nervous system throughout the brain and in the peripheral nervous system as well. Second is that they may be found in blood cells, these myeloid lineage cells that are involved in immune function, for example. And then third, they may also be found in astrocytes or glial type cells. And these are cells that may be activated when the immune system is activated. The astrocytes or glial cells may be found in the brain. And it turns out that glial activation may be one important component that's seen in patients with autism spectrum disorder. When glial cells or astrocytes are activated, they may play a role in shaping the brain during early brain development, pruning synapses, for example. But that these astroglial activation may also be manifest even in adults with ASD as well. And they can be seen, for example, with new PET imaging ligands, where you can show that glial cells are activated in the brains of individuals with ASD. Now, when we look at these endocannabinoids, we can see that there are a lot of different things that may modify the expression in the body. So, for example, when we have stress and we release glucocorticoids, that may elevate these circulating endocannabinoid-like compounds like 2AG or anandamide, for example. Obesity can increase circulating endocannabinoids. Presenting food can activate the endocannabinoids. There are diurnal effects of time of day on the circulating compounds. Exercise may have a powerful effect, but inflammation, infection, and tissue injury also can activate these circulating endocannabinoids. When we activate these endocannabinoids in the body, then these things can have lots of different effects. They can modulate mood and anxiety states. They can increase food consumption or suppress orexin signals for food. They can promote lipid breakdown or lipogenesis, so they can affect the liver. They can decrease satiety signals, so people want to keep eating, and they can decrease pro-inflammatory cytokines in the periphery, these signals for inflammation, for example, or T-cell migration, which is a part of also immune regulation. Finally, we see that these endocannabinoids and endocannabinoid receptors play an important role in key regions of the brain that are involved in reward processing and pursuing reward or goal-directed behavior. So they can be found, for example, in reward pathways like the ventral tegmental area and dopamine neurons that project to these median spiny neurons and to the reward centers like the nucleus accumbens. And there's a GABA glutamate balance, GABA for inhibition and glutamate for excitation that may regulate dopamine signaling and that are influenced by these endocannabinoid receptors that occur in the presynaptic neurons of the GABA and glutamate projections that regulate reward centers in the mesolimbic reward system. So here are some of the compounds that are naturally occurring in plants. There's the delta-9 THC, which is the psychoactive component that binds to the cannabinoid 1 and 2 receptors and other receptors, and that have these agonist effects on different receptors. There is CBD or cannabidiol that has some structural similarities with delta-9 THC. They don't bind to the cannabinoid 1 and 2 receptors. They affect microglia, for example. They affect these coupled G proteins, for example, and then cannabidivarin, CBDV, that may work on different receptors like these TRP receptors, for example. It's also important to know that the THC may have reciprocal or opposite effects than CBD or CBDV on many receptors. Cannabis has been around for many millennia, really, and have existed longer than hops. That's involved, for example, in alcohol, for example. And there are lots of different compounds, over 500 compounds in the cannabis plant. But these compounds are often thought of that may have an entourage effect because they may shape the overall expression when there are multiple different compounds that are presented in the brain, for example. But they really, all the different compounds evolve because they seem to be beneficial for the plant, not for humans, in combating things like viruses, bacteria, fungi, or insects that might harm the plant. The THC, as well as the endocannabinoids, 2-AG and anandamide, bind to a lot of these different receptors, including the cannabinoid and the GPR receptors. And here you show that THC and CBD, they both have anti-inflammatory effects. They decrease cytokines in the periphery. They decrease COX-2 activation, but they also can have reciprocal effects or different effects. CBD also can decrease pro-inflammatory cytokines, affect these G protein receptors, and decrease microglia activation and oxidative stress. So our study is funded by DOD, GW, and Foundation for Prader-Willi Research, look at cannabidivarin CBDV, which is a plant cannabinoid. It has effects opposite to THC. There's no THC in this compound. It doesn't bind to the cannabinoid 1 and 2 receptors. It binds to these GPR55, G protein coupled receptors in these TRP sites. CBDV has anticonvulsant activity. It decreases seizures, it decreases excitation, and enhances inhibition. So it improves the excitation, inhibition, and balance. And it has these anti-inflammatory properties. peripherally like cytokines and centrally like astroglia. It reverses aberrant synaptic plasticity in animal models, and it has some antipsychotic and anti-addictive effects in animal and human models. There is evidence that the endocannabinoid system gets activated in patients with autism spectrum disorder and in related syndromes like Fragile X syndrome, and then in other autoimmune or inflammatory illness as well. And CBDV has been studied in animal models of epilepsy, this tuberous sclerosis model, where it decreases excitation to inhibition and decreases seizures. It's been studied in a Fragile X animal model and has been shown to enhance social functioning. It's been effective in an animal model of autism, this valproate mouse model, where mothers exposed to valproate have offspring with social deficits and repetitive behaviors, and treating the offspring who have repetitive grooming behaviors with the CBDV decreased the compulsive behaviors. And it's been studied in a Rett syndrome animal model where it seems to enhance neurocognition. And in some human studies of refractory epilepsy, it's been found to have anti-seizure effects. So the study that we're actively recruiting for now is 100 children age 5 to age 18, so children and adolescents. And we start at lower doses, but we go up to high doses, up to 400 milligrams twice a day, based on the weight of the individuals. It's a randomized parallel design study, so everybody gets randomized either to the active medicine, CBDV, or to placebo. It's a 12-week study, and it's taking place at Montefiore Einstein in New York and in the Bronx, as well as NYU. We're collaborating with Oren Davinsky there. And this compound, again, works by reestablishing excitation-inhibition balance and decreasing immune inflammation. So here's the study. Patients are randomized for 12 weeks to cannabidivarin or placebo. The dosing is up to 10 milligrams per kilogram per day, starting at a low dose, 2.5 milligrams per kilogram, then 5 milligrams per kilogram, 7.5 milligrams per kilogram, and 10 milligrams per kilogram, up to a maximum of 400 milligrams twice a day, or 800 milligrams. Then patients are off the medicine for 2 weeks, and then we follow them up and see how they do off of it. They come in for study visits every 2 weeks. The primary outcome measure is looking at these disruptive behaviors, in particular irritability. So aggression, self-injury, or disruptive behaviors with this aberrant behavior checklist or ABC irritability subscale. The second core feature that we're looking at are the repetitive behaviors measured by the repetitive behavior scale revised. And then we've developed a Montefiore Einstein rigidity scale that looks at craving for sameness, discomfort when there are changes, either in terms of the environment or in terms of the schedule, where people can experience discomfort and then protest or explode. So we're looking at rigidity and repetitive behaviors. And then finally, we're looking at the social communication with the ABC social withdrawal scale. And then we're looking at other global measures, including quality of life measures, the Vineland scale, and the CGI. So we'll get at a number of different domains. Irritability, which is a big problem for families with autism, where people can protest and explode. Repetitive behaviors that become a major challenge, and then social communication problems. And then we're looking at quality of life and global measures. This is the first large-scale study of this particular cannabinoid, CBDV, in autism spectrum disorder. It avoids the effects of THC, which is a psychoactive compound. This is a non-psychoactive compound. It has less adverse events or side effects than the chronic use of some of the other treatments that are currently used for irritability. Those atypicals can be associated with side effects like metabolic syndrome or weight gain. And it's not medical marijuana. Medical marijuana actually has an indication in certain states, like Rhode Island or Pennsylvania, where autism may be an indication for the use of medical marijuana. And then groups like Autism Speaks have addressed this, and this whole plant access for autism has looked at people who have used medical marijuana. This is not a study of medical marijuana. It's one particular component, this cannabinoid, cannabidivarin, that does not have psychoactive effects in autism. Now, we've had to overcome a number of these regulatory hurdles and work closely by filing an IND with the Food and Drug Administration, working with the human subjects individuals at the Department of Defense, working with our IRB at Albert Einstein College of Medicine, working closely with the Drug Enforcement Administration, the Bureau of Narcotics. We've had to develop special issues in terms of a special safe to store the compound and dispense and provide accountability and security. We've gone through a number of legal and contracting issues and intellectual property issues in order to do the study. We're also doing a study in a related syndrome, Prader-Willi syndrome, which is a rare condition that has features of an autism spectrum disorder where individuals don't express the father's genetic imprinted material on this region on chromosome 15. These individuals have mild intellectual disability, mild hypotonia, but substantial hyperphagia or compulsive eating, which can lead to obesity, and lots of repetitive and compulsive behaviors, including things like skin picking, leading to tantruming and some subtle social cognition problems. These people early on may not eat, and then after age 2, they can develop compulsive eating problems. We're conducting a 12-week study comparing cannabidivarin to placebo. And these are individuals age 5, but up to young adults age 30, 36 children and young adults with Prader-Willi syndrome, where we're also looking at irritability as the primary outcome. We're also looking at these compulsive behaviors and rigidity, but we're looking at things like hyperphagia, the number of days per week that people binge, and then their overall weight and their basal metabolic inventory. There's some evidence that there may be a decrease in eating and weight with cannabidivarin. We're looking at the sleep quality and then other global and quality of life measures as well. There is one plant-based cannabinoid, Epidiolex, which is a form of CBD developed by GW Pharma that has been approved by the Food and Drug Administration for the treatment of 2 rare forms of epilepsy, Dravet syndrome and Lennox-Gastaut syndrome. And this is marketed for children age 2 and up with these 2 rare forms of epilepsy. Individuals want to follow liver functions while on the Epidiolex and look for things like some sedation, for example. You start with relatively low doses, and it's based on milligram per kilogram, 2.5 milligrams per kilogram, and can titrate up to 20 milligrams per kilogram per day. And it comes in an oral solution of 100 milligrams per milliliter in a liquid form that's in a sesame seed oil. Again, this is FDA approved, but for these 2 rare forms of epilepsy. There are some individuals who are using other over-the-counter type CBD preparations, and there are various manufacturers, and it can come in an oil form, can be 2.5 milliliters twice a day. These are not FDA approved, so none of these things have the FDA approval, so they haven't proven safety or efficacy, and they haven't done necessarily good manufacturing practices to establish their particular milligrams that are found of the different compounds in a preparation. So they may vary in potency or milligrams of CBD or even THC, and the risk versus benefits haven't been established in specific disorders. As I mentioned, these cannabinoids have been used in epilepsy, the Epidiolex that I mentioned, for the rare forms of epilepsy. Sativex is another form which has a blend of CBD and THC that was approved by the EU for the treatment of MS in relatively low doses. And Zynerba Pharmaceuticals has a transdermal gel of CBD that they're currently studying in some rare conditions like Fragile X. This is the data from the CBD trial of Epidiolex in Dravet syndrome, where there was a higher rate of change in the number of seizures and a higher rate of the responder rate with the active compound versus the placebo. And this is the study in Lennox-Gastaut syndrome, where there was also a higher rate of responders and a higher mean change in the number of seizures with this Epidiolex and LGH. Now, there have been some studies, particularly in Israel, using blends that have a ratio of CBD and THC. And here you see the two different compounds. THC does not have any FDA approval, and there are risks and benefits with that psychoactive compound. And different compounds, the THC, CBD content can vary. There are anecdotal case reports in the ASD, and there have been several trials in Israel with different plant-based compounds that have different CBD to THC ratios, mostly of a 10-to-1 CBD to THC ratio that has shown some tolerability and some efficacy, but hasn't been FDA approved, and still additional research needs to be done. I mentioned this other group, Whole Plant Access for Autism, where they have assessed about 33,000 patients with ASD who may have had some kind of individual anecdotal type treatment with cannabinoids. There are some negative side effects with THC as well. So THC can trigger psychosis in some individuals, particularly in the compounds where there's a high THC content like skunk. That may be particularly risky for some vulnerable individuals. There can be cognitive difficulties. There's an addiction risk. There can be a pro-convulsant effect of THC as well as an anti-convulsant effect, and that these compounds can have effects on the developing brain. And so there's a lot of work that needs to be done in young individuals to make sure that there are no long-term developmental problems and to understand the risks and the benefits of anything that has THC in it. So our work has been with the CBDV compound in both children and adolescents with autism spectrum disorder and children and young adults with Prader-Willi syndrome. We're targeting specific domains, and these are sort of an experimental therapeutics approach based on our underlying mechanisms of imbalance of excitation and inhibition and activation of immune inflammatory mechanisms. And then we're also using this orphan disorders approach to look at rare, more homogeneous conditions and see if we can get even a larger drug versus placebo effect in a population that has more genetic homogeneity. And if individuals want to participate in the clinical trials at Albert Einstein College of Medicine or Montefiore Medical Center, they can contact Dr. Bonnie Taylor. Her email address is botaylor@montefiore.org, and her phone number is 718-839-7530. So that concludes my presentation. We have some time. I'd be glad to take some questions if there are any questions. Thank you very much for your attention.
Thank you for that presentation, Dr. Hollander. We do have a lot of questions, as you can imagine. So people who are still on the line, you can type your questions into the question section, and we've got about 10 more minutes. So I'll be reading some of these questions to Dr. Hollander, and he can help us out here. So the first overarching question that I have is about getting enrolled in studies. There's a lot of curiosity about how to get into a study. So do you have insight about your own study or any other studies you're aware of?
Yeah, thanks for that question. And again, on a slide that I'm showing now, you could contact Bonnie Taylor at Montefiore and Einstein, and her email is botaylor@montefiore.org and 718-839-7530 for studies in the New York area. You can also go, for example, on the Foundation for Prader-Willi Research, and that will direct you to either to our studies or to other studies that are going on with Prader-Willi syndrome as well. And then there are other advocacy groups, I Care for Autism, for example, Autism Speaks, this whole plant access for autism, and they may have links to other kinds of clinical trials that may be going on as well. And of course, the Autism Research Institute, which is hosting this webinar, I may be able to direct people to studies.
Yeah, I know often it's limited by where people are located. So thank you for giving us a number of different resources about that. So lots of questions about drug interactions. A lot of our loved ones on the spectrum are often on different medications, and you touched on that quite a bit. So I appreciate you reviewing that. One specific question that came up was about, have there been specific observations about risperidone and CBD or CBDV use, and how clinicians would monitor that if they were working with that?
Right. So those are two important issues. One are drug-drug interactions, and I do think it's important for clinicians to be aware of potential drug-drug interactions, and then also for families and patients and other stakeholders to know about this. And this is true for all kinds of alternative treatments, as well as anybody using cannabinoids, for example. Some of the compounds in the plant, for example, may have effects on different liver enzymes. And many medications, one of the ways that medicines may be metabolized is that they get broken down by different liver enzymes. And so if a plant-based cannabinoid is having an effect on a liver enzyme, and that liver enzyme is involved in the breakdown of a medicine, then there's a potential for a drug-drug interaction. Two drug-drug interactions that have been noted, for example, with CBD or the prescription form of that, Epidiolex, are valproate or Depakote or clobazam, which are both anticonvulsants that are used to treat epilepsy or treatment-resistant epilepsy as well. And in the studies that were done with that particular compound in some of the rare forms of epilepsy and others, there is a potential to have some impact where taking the plant-based compound may affect the plasma levels that you can measure in the blood of the valproate or clobazam, or they may have some impact as an interactive effect in elevating liver functions, which can be monitored by blood work, for example. So that is something to be aware of, and there can be some drug-drug interactions with other, alternative treatments as well, and it's helpful to understand that, and sometimes to do routine blood work to check for the routine liver functions to make sure there's no elevation there, or if people are on certain types of anticonvulsants, not others, that the blood levels of those anticonvulsants haven't increased, for example. There are a number of people who are taking risperidone or aripiprazole to target the disruptive behavior, so severe aggression or self-injury or temper tantrums or irritability. I mentioned those medicines can be very effective for those symptoms, but can be associated with some early side effects or long-term side effects. And also some of the people who are on those medicines may also be on the plant-based cannabinoids as well. One potential for drug-drug interaction is that the plant-based cannabinoids can sometimes cause some sedation, for example, and those compounds also can cause sedation. So there could be a additive effect that you want to look for to make sure that patients aren't getting sleepy on the combination. You might want to monitor, for example, liver functions as well, just to make sure that neither compound is having any impact, for example, on liver function. It doesn't seem to be that this will have an effect in terms of elevating the blood levels of those medications, though.
Right. I have a lot of questions about sourcing. So I know you named the different products that you're using in the study. There are tons of these things available commercially. So do you have any insight about if people are purchasing these products, how they should go about selecting carefully?
Right. So our study involves a experimental therapeutic compound, the CBDV, and it's manufactured by GW Pharma, and we're working closely with them. It's an experimental compound, so it's not available for use outside of a specific clinical trial. I mentioned that there was one form of CBD that has been FDA approved for these two rare forms of epilepsy, the Lennox-Gastaut or Dravet syndrome. And that's something that is prescribable and that comes in a liquid form, and where there's good manufacturing process, and you know exactly how many milligrams you're getting of different compounds, for example, and there's data on safety and efficacy. Then we're in all of these other CBD compounds that people can obtain on the internet or in health food stores or in the pharmacy, for example. And the FDA has recently issued some words of caution with regards to that, in that the FDA hasn't, approved CBD in other contexts for any particular reasons, and they haven't gone through the rigorous approval process. They don't have safety and efficacy or good manufacturing process, and that individuals or companies shouldn't be promoting them for specific disorders as opposed to sort of symptoms or for general health. And there are a lot of different providers of CBD, for example, and some of the different providers have been rated in terms of the quality through Consumer Reports or other things that you can go on to look at. And people have essentially dosed these things in either low-dose approaches or high-dose approaches. People have used low-dose approaches for things to target sleep or anxiety, or higher dose approaches to target things like epilepsy. And clinicians often go to relatively high doses of those compounds to target things like epilepsy. When you go to high doses, then you may get effects with different compounds within the plant. It's possible that those different compounds may have synergistic or they may have antagonistic effects. So that's something to consider. I've mentioned some of the clinical trials that were going on in Israel, looking at some of the whole plant in different sort of blends in ASD, but there haven't been any compounds that have been approved in this area. But I guess families, individuals, clinicians are utilizing these. So it's important for clinicians to understand the potential benefits and risks, information about dosing, information about drug-drug interaction. That will be helpful in managing individual patients.
So you may have already said this, so I apologize if I'm asking a question you already answered. I've had several people ask about when the DoD study you're doing now will conclude, like when you're expecting to have results and report your findings.
Well, when we get up to 100 subjects, then we'll complete the enrollment. So we still have another couple of years, I think, until we are able to hit our enrollment target. So it will take a little bit of time before we're able to get the results. And one of the reasons for doing clinical trials is to make sure that the active compound is better than a placebo. People have expectations, and those expectations can sometimes bias how they report. The way to develop new treatments is to do these rigorous placebo-controlled trials and then show that there's significant efficacy and tolerability. That's why we do these clinical trials.
All right, last question, and thanks to some people who posted different suggestions about researchmatch.com and other places where people might be able to find studies near them. I did have a number of questions from people who are tuning in from overseas. Are people from overseas, are they permitted to enroll in your study, or is it US only?
I think of it as a challenge because of some of the regulatory constraints. So I don't think we're allowed to enroll people from overseas in this particular trial. It's a US candidate.